this video, we will discuss cosmetic eyelid and periocular surgery. Cosmetic eyelid surgery is based on understanding age-related involutional changes rather than treating isolated eyelid defects. Age-related changes around the eyes lead to functional and cosmetic concerns. These changes affect skin, muscle, fat, tendons, and bone. Involutional changes of skin and soft tissue. Reduction in skin elasticity and thickness, loose, wrinkled, and redundant eyelid skin, dermatochalasis of upper and lower lid. Loss of dermal collagen and elastin leads to excess eyelid skin, which is the commonest reason patients see cosmetic surgery. Involutional changes in septum and fat. Weakening of orbital septum, anterior prolapse of orbital fat, and prominent upper or lower lid fat pads. Fat prolapse produces the classical baggy eyelids seen in elderly patients. Involutional changes in muscles and tendons. Stretching of canthal tendons, levator aponeurosis attenuation, lower lid retractor laxity, which results in lid laxity and ptosis. Aponeurotic ptosis is a key involutional change and must be identified before cosmetic surgery. Involutional changes in fat and bone. Atrophy of orbital and eyebrow fat pads, inophthalmos and brow descent, and thinning of periorbital bone. Aging leads not only to fat prolapse but also fat loss, giving a hollowed appearance. Involutional changes in brow and midface. Weakening of frontalis muscle, descent of eyebrows, increased upper eyelid skin redundancy, and midface descent causing tear trough deformity. Brow ptosis often contributes significantly to apparent upper lid dermatochalasis. The non-surgical techniques are botulinum toxin, tissue fillers, and skin resurfacing. Botulinum toxin offers temporary cosmetic improvement but requires precise injection technique. It is used for periocular wrinkles. It reduces crow's feet and glabellar lines and acts by weakening orbicularis and brow depressors. The complications are temporary ptosis, lag of thalamus, and diplopia. Tissue fillers are injected deep to orbicularis to restore lost volume rather than tighten skin. It is used to correct wrinkles and volume loss, commonly used in tear trough and hollows. Hyaluronic acid is most commonly used and the temporary effect lasts for 3 to 12 months. Autologous fat provides a more permanent volume. Skin resurfacing complements blepharoplasty but does not correct lid laxity or fat prolapse. Chemical peels and laser resurfacing are used for this purpose. They improve pigmentation, texture, and fine wrinkles. The surgical techniques are upper lid blepharoplasty and lower lid blepharoplasty. Upper lid blepharoplasty is both cosmetic and functional in many patients. The indications are dermatochalasis, pseudotosis, and visual field obstruction. The procedure involves removal of excess skin, selective removal of orbital fat, and correction of ptosis if present. The complications are excess skin removal causing lag of thalamus, dry eye and exposure keratopathy, and hollowed upper lid due to excess fat removal. Lower lid blepharoplasty. Lower lid surgery carries higher risk and requires careful patient selection. The indications are excess lower lid skin, orbital fat prolapse, and lower lid laxity. The approaches are anterior skin muscle flap approach used when excess skin is present and posterior transconjunctival approach used when only fat prolapse is present. The complications of lower lid blepharoplasty are lower lid retraction, ectropion, contour abnormalities, and lateral lid droop. Brotosis. Failure to recognize brotosis can result in undercorrection. It frequently accompanies dermatochalasis, may follow facial nerve palsy or trauma. Correction may be required before blepharoplasty. Brotosis correction techniques. Choice of brow lift depends on patient's age, hairline, and cosmetic expectations. In direct brow lift, incision is given above the eyebrow hairs. It gives a simple but visible scar. In endoscopic brow lift, small incisions are made in the hairline. Forehead elevation with fixation is done. Some exam relevant points are dermatochalasis is excess skin, not true ptosis. Always assess brow position before blepharoplasty. Lower lid surgery has higher complication risk. Transconjunctival approach preserves lid stability.